all patients were seen by the teleradiology or from the distance, and the expertise of touching, palpating, and talking to patient was missing. There where the radiology came in to fill that gap. You see the patient, make some opinion without touching patient, send it to us, and then by doing the relevant investigations, we do try to give you the best possible diagnosis and follow it up along with you to the management also. So that was the purpose of choosing this topic, the diagnostic imaging in COVID-19 and overview, which would take us to the importance, possibilities in diagnosis and possibilities in predicting prognosis, and also in dealing with the possible complications and assessing them radiologically. I am fortunate to have been flanked by two eminent radiologists of the town, Dr. Saket, who succeeded me in Regency Hospital as head of the department, and Dr. Gurpreet Singh on my left as succeeding me in my practice in town. Both of them are extremely knowledgeable, and I'm really happy, honored to have them around us. So Dr. Gurpreet would be chairing the session and would introduce the speaker of today, Dr. Danny.
Respected seniors and my dear friends, it gives me immense pleasure and a sense of humility to be able to introduce my HOD and head of department professor, Dr. Nandini Paving. We did a BC and she is one of the most dynamic I have met in my life. And she has been professor for over 20 years now. Many numerous publications, inspector for radiology, examiner of PG, and NABH inspector, multiple publications, running a tele-radiology department as well in her own setup. Ma'am, I, with all humility and pride, welcome you to this prestigious forum of IMS CGP Kanpur. And I know this will be a great talk. Over to you, ma'am.
You
have to unmute yourself. Unmute yourself.
Good evening. Can we start, Dr. Gurpreet?
Yes, yes, we can start. You can ask Jigar to say this thing.
Yes, ma'am, you can start. We can see you and we can
Okay.
hear you.
So good evening to the Indian Medical Association, Kanpur, to the office bearers, and thank you very much for this privilege. We would like to share a few basics about lung imaging, especially related to COVID today. Let us start with the first slide. The slides are being shared by my department in Jamnagar, as I happen to be traveling at present. Dr. Jigar is helping me with it. Jigar, where can we start? So, as we know that the coronavirus started in Wuhan last year, or rather in 2019. And after that, it was declared a pandemic. And 25th of March, the first case was detected in Thrissur. And then it spread like a wildfire. So next slide. On the 15th of July, the first vaccine trial started. And today, that is recently, we have 24 crore vaccinated people. But still, India being a population of 1.4 billion people, we are still short. Around 24.5% of our population is vaccinated. And still, so we are still fearful of the third wave and how it will affect us. So this is a brief timeline about the various vaccination. And next slide. So this is the COVID-19 dashboard of how many samples were tested, how many positive cases were there, which most of the doctors here are already aware. But we have a long way to go. And as practitioners and physicians, we need to know how to detect early, because early detection and early treatment, getting a patient to hospital early before they are starved for oxygen, has been the biggest savior rather than any medicine, as we know that we still don't have a foolproof medicine. So mostly it is symptomatic treatment and oxygen. So we want to be able to detect patients before the disease has affected them very badly. Next slide. So this is the status in India, and how various places are showing the viral load. So these are the various, next slide, about the epidemiology, about the various phrases which are used, about an outbreak, what is an endemic. An outbreak is more disease than could be expected, like measles, which is the most commonly known outbreak we know. Then endemic are those diseases which occur in certain areas, like just now we have the Nipah virus, which is in Kerala, but it is nowhere else. But one has to be careful also in other places. And an epidemic is a regional outbreak, and a pandemic is then when it is worldwide and rapid spread of disease, as we know about COVID. Next slide. So this also we know. Hello. So the SARS-CoV, as we know, is believed to have started from a mammal, that is a pangolin. Pangolins are used in Chinese medicine.
I'm sorry to interrupt. The slides you speaking on a slide which Jigar is posting are different. So the coordination is not happening. So let us ask Jigar to give you the slide number, and accordingly he changes. He possibly is not listening. Dr. Gurpreet is talking to Jigar. Maybe once we come back to you.
Next. So we were on this slide. So as we know that it has been traced to the pangolin, which is used in Chinese medicine for experiments. It is mammalian, and it was found in the wet market in Wuhan. Next. Next slide. So this is how infective it is. Normally, in influenza, 1.5 people get affected. In COVID, one person is able to give the disease to 5 people, nearly. That is how it spreads so fast, and hence it is a cause for concern. Because as we know that the patient becomes symptomatic between 5 and 8 days. So by the time it is the 5th day and the patient is symptomatic, the patient may have infected a large number of people. So if we detect it as early as possible, we will prevent the community spread also, and we may be able to save the patient's own worse prognosis also. Next. Next slide. Next slide. Next slide, please. I think Gurpreet also has the presentation there. So can you play it from there itself, Gurpreet? Are the slides visible?
Ma'am, what did you get also now from this coronavirus COVID-19 SARS-CoV-2 like an ambulance? Am I audible to you? Can you hear me? Hello.
Yes, so I'm sorry for the mismatch. And so we saw how it is transmitted through a pangolin. And next slide. So what is the structure of a coronavirus? And so we also saw that one person is able to infect 5 people. That is how contagious it is. And the maximum load is between 5th and 8th day. So by the time, if we detect it late, not only is it poor prognosis for the patient, but also the patient may have infected a large number of other persons. This is the reason why we saw that whole families were coming. Next slide, please. Next slide. Next slide, please. Next. So what is the structure? The structure is that it is mainly the fact that it has a very large mRNA genome. That is, it is a very primitive virus. So it has a enveloped by positive stranded RNA, and it has a lipid bilayer. This lipid bilayer is the key to our protection. Hence, when soap and water is the best protection. And because it has crowns as spikes, hence it is known as a coronavirus. And the spikes allow it to attach to the human cell receptors in the upper or lower airway and multiply there. Next. Next. Next slide, please.
We are on the 13th slide.
But it is not moving on. So let's have the next slide, please. After the structure.
And we are on the comorbidities and risk conditions.
Let us go to the lung structure. The lung segment slide. Can we go to the lung segment slide?
We are there only.
But how come it is not changing on the screen?
we can see we have the 13th slide where you have shown us the islands of lung.
Where we are?
Island.
Yes.
I think, Gurpreet, you should present because there is some lag here. So if you go on to the lung segments, you have done so many HRCTs there. I suggest that you continue with this. I will listen and I will add if I want to add something. Can you take over, please?
Yes, ma'am.
So I'm also listening and I will add in between. But please, because otherwise it gets boring for everybody else who's watching. There seems to be some mismatch. So please continue. The slides are pretty self-explanatory.
Okay.
Please start.
Am I just start?
Yeah, please start. Please start. Carry on with the presentation, no? You speak.
We are just trying to fix it. We are just trying to fix it. See why it's not moving on the Zoom platform. Because we are seeing it moving there.
आप explain कर दो. Slides तो easy है. You will be able to explain.
Explain is not giving for the people also who are logged in. So is it changing on your screen now? Now is it changing on your screen?
Can you see it on your screen?
Yes. Shall we continue?
Yes, ma'am.
All right. So the basic to understanding the radiology of the involvement of the lungs is to understand the segmental anatomy. So as we can see in this picture, both the lungs have a number of segments and their orientation is fixed depending upon the major and minor fissures. So the number of segments on each side are 10, though the fissural configuration is different. So depending upon the number of opacities we see in each segment and the number of segments involved, the CT Severity Index, as it is popularly known, which predicts the prognosis of the disease, as well as the cytokine storm, which was the dreaded thing. And when the CT Severity Index and the cytokine storm was more, then tocilizumab was being given. So this is the important thing, that there are 20 segments and 2 points were allotted to each segment. So the score was established in that manner. Next slide, please. Yes, so this is another view of the same. What we see in the center is the artery, vein, lymphatic and airways complex, which is called the hilum. And from there are branches of the airways going to various lung segments. Next. So as everybody familiar with the X-ray of the lung knows, normally the lungs appear black because they are filled with air. And we have a central white opacity, which is the mediastinum, which contains the mediastinal structures, that is the heart, and in the posterior mediastinum, the blood vessels, aorta, etc., and the esophagus. Otherwise, the aerated portion is completely black because it contains air, which is radiolucent. Next slide, please. And the same thing, the segments can be seen on a CT cross-section. The CT, of course, is a perpendicular orientation of the X-ray, and it gives us much more fine information about the various areas of the lungs and also what we know as hidden areas. That is the areas behind the heart and the great vessels, which sometimes get overlapped on an X-ray. Next slide, please. Yes, so this is the typical X-ray. Now, instead of being black, in the COVID pneumonia, especially, we see such fluffy opacities. So these fluffy cotton-like opacities, when they converge, they are known as ground glass opacity. So what is ground glass? Ground glass is that whitish opaque glass which we use very often instead of clear glass. That is where the name comes from. So what is happening is the reaction of the body to any infection is to produce edema, fluid, and a response of white blood cells. So this edema, it is trying to drown the infection, or it is trying to clear the infection by drowning it. That gets filled into the alveoli, and the alveoli start appearing white, and this is called ground glass opacity. And it was typically seen in COVID that it did not respect segments, and it was more located towards the periphery. Next slide, please. So this is the same lateral view of the same. And now in the era of digital X-rays, the quality of X-rays is really good. And we were, in many cases, especially initially, when the RT-PCR was not so easily available across the counter, and people were not able to get access to it, X-rays and CT scans have saved the day by providing diagnosis early and saving many lives. In fact, I was officer on special duty and I was posted to Surat, where we had a large outbreak and there's a civil hospital there. So the patients, to our surprise, would come with an HRCT scan in their hand and come to the OPD with it and say कि मुझे इतना % कोविड है तो मुझे आप एडमिट करो, नहीं तो मेरे फैमिली को हो जाएगा. They would have not have an RT-PCR, they would have an HRCT in their hand. And I have some colleagues who are doing HRCT there. They were tired. They were doing 250 scans a day. They were tired, but it helped to contain the epidemic. Gujarat responded in a big way, though we had, like every other place. But because of this, and if there was no RT-PCR, people would do an X-ray, they would do HRCT, and they would, because they were more scared about the families, about the elderly people in the families, and they would isolate or come to the hospital. Next, please. So this is the CT appearance. So the same thing. As you can see, most of these white opacities, what we call ground glass opacities, are all situated towards the periphery. So this was the typical appearance of COVID pneumonia. Next, please. And so this is another appearance. This is called crazy paving. Crazy paving is that the interlobular and the interlobular septa also start getting thickened. Normally, they are of hairline appearance. They are so thin that they are barely perceptible. Next, please. So you can see what is branching here is the bronchi, and normally they are not seen, except very rarely you can see the early part, the walls, but here because they are filled with fluid, and also there are widened vessels because the blood supply increases. Next, please. Yes. So ultimately, when there is resolution, it was healing with fibrosis. So some follow-up cases have shown us this traction bronchiectasis because the lung segment which was healing would fibrose. Hence, because of this radiological appearance of traction bronchiectasis and further follow-up led to the use of steroids. Though we noticed that if the steroids were overused and abused later on, we had cases of mucormycosis, but steroids have been found to have wonderful effect in reducing the morbidity and mortality of these patients. Given early, given in the right dose, they prevented the inflammation, because this is ultimately the inflammation and the cytokine storm which was killing the patients. Next, please. So again, we can see architectural distortion, subpleural bands. So this is in later stages. We found that even after 14 days, when the patient's RT-PCR had become negative, the opacities were not disappearing necessarily in some patients. The lung findings were taking a little longer. The patient was no longer infective. We must remember that infectivity also depends upon the viral load. So once the patient gets infected, then the virus multiplies. It's like a bell curve. Between 5th to 8th day, the patient is most infectious. Then the patient starts shedding the virus. And then between 18th to 14th day, the viral load starts becoming less. And after 14th day, even if the patient is not RT-PCR negative, the patient is no longer infective because the patient is not shedding so much virus. However, on follow-up, this is the picture we saw, that there were 5 bands and there was architectural distortion. So these patients needed physiotherapy, breathing exercises. So there is a whole new concept of post-COVID rehabilitation. And these are the kind of patients, especially if they had widespread involvement, who then had what we know as prolonged COVID. And these were the patients whom we advised that please rest. Please do not do too much exertion. Please have more fluids, because we all know that it causes fibrosis. It is causing thickening of blood. In some cases, we have seen thrombosis, and patients should not take it lightly. It is, after all, a viral disease which is quite vicious, and we are still to understand many aspects of it, and it is also mutating. Next slide, please. So now this is what are the CORADs, which is the basis of the radiology. So what is CORAD 1? That the CT finding is normal and the level of suspicion is also none. But very often the patients would come because somebody in their family had COVID. So they would want to have their CT scan done. Now we must understand that though we do not recommend unnecessary CT scans or unnecessary X-rays, but if a person is very anxious, or if a person has comorbidities, and if a person is losing sleep, we are of the firm opinion that once in a while it is justified to do that CT scan and put that person and the family and their mental peace is equally important. that one odd CT scan is not going to harm them. When you see the ratio vis-a-vis the anxiety levels which families were experiencing. Now, CORADS 2, that is low. So, we must remember that though there is COVID and there are still other upper respiratory tract infections also prevalent. So, the patient may have some opacity, patient may have a mild cough, but it may be something else. That is CORADS 2. CORADS 3, indeterminate. That there are a couple of opacities or maybe one opacity. So you want to follow up these patients. Basically, CORADS 2 and CORADS 3, it is very important to maintain a high index of suspicion rather than be complacent. CORADS 4, that the abnormalities are suspicious for COVID-19. We saw those peripheral ground glass opacities, etc. And in the correct setting, in these times, we would say that it is pneumonia, which is very likely to be atypical pneumonia, as we call it, meaning COVID. CORAD 5, very 5, and there is typical COVID-19. That is peripheral, large number of fluffy opacities and ground glass appearances, which is typical of COVID. And CORAD 6 is there is also an RT-PCR, which is positive. So there is no doubt. So about RT-PCR, again, it depends upon the technique. Then it also depends upon the day of examination. If the RT-PCR is done too early, it may be negative. If it is done too late, it may be negative. Next, please. So again, we have already seen the CT changes over time. So 0 to 4 days, we have this ground glass opacity, partial crazy paving, and the number of involved lobes are less. Then in 5 to 8 days, which is the progression, the ground glass opacity will increase, all the findings will increase, crazy paving will increase, and 10 to 13 days, they will congeal together, coalesce, there will be consolidation. And greater than 14, gradual resolution. So it is important to remember that like you have a bruise, you may not have pain anymore, but the bruise and the resolution of that bruise takes nearly 6 weeks. It doesn't disappear at once. Similarly, all this edema and the ground glass opacity, the patient may become RT-PCR negative, but a few lung changes may persist for some time. So the patient should not also be overexposed, or the patient should be counseled that it will take some time for the lung changes to disappear. Next, please. So the lung CT features, as we have seen before, in the first, in the second, and in the third, like we were saying, early, between 5 to 8 days, after 14 days, and also depending upon the severity. And the clinical symptoms are given along with. Sometimes patients were completely asymptomatic, but they had COVID findings in their lungs. It also depended upon the patient's own resistance and general health. Next. So these are some few cases that this is CORADS 1. It is all clear. We cannot see any opacities. The lungs look black. The branching looks thin. So we are not suspecting any COVID. Next. CORADS 2. That little we can see a few like twinkling stars in the chest, but still we are not suspecting any COVID. It may be some other infection, there is some tree in bud, but we do not see any ground glass opacities. Next, please. The CORADS 2. Here we can clearly see peripheral opacity, and it is not very dense. It is grayish. This is called ground glass opacity. In between, we can see some branches of the bronchi. And the patient also had fever and cough. And we are suspecting COVID, but it may be a bacterial infection also, because patient had expectoration also and fever and cough. So it is also necessary to be cognizant that other diseases have not disappeared. So CORADS 2 is indeterminate. It may be COVID, it may be some other infection. Next, please. All right. So depending, now this is a very, very nice ground glass opacity, if you notice. So it has a very less dense appearance than the previous CT. It is like that gray colored opaque glass. This is the ground glass opacity, and given the right background, we would think of it, this is unifocal GGO and the patient may have fever, patient may not have expectoration, but the patient will have a little fever and he has this ground glass opacities. Then the score of the CT severity was dependent upon the number of these ground glass opacities. Next, please. Now this is classic case. This is case 5, where it is also on a day 5. And this is very typical. We saw a number of these bilateral central consolidations. There is GGO. There are peripheral opacities also. And this was a consistent finding in COVID. This we would definitely stamp as COVID. Next. Again, you can see all these ground glass opacities and the number of these ground glass opacities in the various segments have to be counted, which gave us the CT Severity Index. Next, please. Again, very typical. And there is bilateral GGO, which would in these days make us suspect COVID. Next, please. More of the same. See, especially in the periphery, all the corners have to be checked. One has to count the segments and count the number of opacities. There are also vascular thickenings and there are some subpleural bands. Next, please. This is on the 11th day of complaint. We can, it is very obvious to the naked eye that the infection is much more widespread. And this patient was also RT-PCR positive. Next, please. Again, a similar case where it is beyond doubt, looking at the amount of widespread involvement in both lungs. Next, please. So again, there is multifocal ground glass appearance. And one must remember that this is a viral disease. So sometimes the clinical picture, so symptomatology, and the investigations don't match, which is typical of a viral infection. That sometimes there's paucity of signs and the symptoms are much more. Sometimes like this, there will be widespread involvement and the patient will not be so symptomatic, but we must remember that we encountered something called happy hypoxia. That the patient was going into hypoxia because his lung involvement was so much, but he was completely unaware. And because he was unaware, he did not rest. He did not come early to the physician. He did not get admitted. And his SpO2 was dipping. It was below 90. And suddenly the patient will collapse. So in patients who had such CT findings, one would definitely be more cautious. We would warn the patient that the lungs are involved, that they should rest, they should measure their SpO2 a number of times a day, measure their temperature and be extremely careful. In this manner, the CT scans were very, very useful because we lost a lot of patients because they would come late and because they were unaware that there was something called happy hypoxia. Next. Similarly, the bilateral GGO and what is known as the halo sign, which we found very typically. If the arrow shows a halo sign, that there is a central opacity, then there is some loosened lung, and again, there is an opacity. This is considered pathognomonic of COVID. Next, please. So, again, ground glass opacities, which is COVID, and now along with that, we have collection thickening in the ethmoidal sinuses and the left maxillary sinus and inflamed extraocular muscles. So the very sad part, along with COVID, in the end of the second wave, we found a large number of this unusual fungal infections, mucormycosis, and it was heart-rending. We had number of patients in our hospital also, and there had to be enucleation, and they had to receive lysosomal amphotericin was not available so easily except in the government hospitals. They had to take prolonged treatment. The government made Herculean efforts to make it available. And we also had cases with mucocerebritis. As we know that India has become the diabetes capital of the world. And if COVID has taught us anything else, it has taught us the importance of being fit. Large number of people started taking their fitness much more seriously and their sugar intake and sugar levels much more seriously post-COVID. Next. More of the same with restricted diffusion in the left maxillary sinus, left middle nasal turbinate. This is the most heartbreaking and heart-wrenching thing to see patients who have mucor and who need operation, and then the post-op MRIs, etc. I mean, we have seen so many things as doctors who have practiced for a large number of years. It was actually like one of those sci-fi movies. And it was like, one of those science fiction movies, actually, the appearances and the appearance of the patient after enucleation, etc. So one must catch it early. One must take all precautions not to get it. We must still consistently educate our families, educate our patients, and everybody we know about the need to be cautious. Next. Same. The involvement of the turbinates, the involvement of as you can see, there's proptosis because the muscles of the eye are involved. And it is called the black turbinate sign, the red arrow, because fungal infections will cause this sign, which is called the black turbinate sign. Next, please. More of the same. The enhancement in the post-contrast image peripherally, because inside there is some inspissated collection. Next, please. This is how the pathological picture of the hyphae and of the fungal ribbon looks. Next, please. More of the same, mucosal thickening, orbital wall extension, and thysis bulbi. Next, please. More microscopic pictures with lactophenol cotton blue stain with a ribbon-like hyphae and the MRI picture. Next, please. The X-ray picture of the frontal ethmoidal and maxillary sinuses and the involvement. But for this, MRI is diagnostic. MRI also helps in the planning of the surgery. Also, contrast MRI will show early involvement. Diffusion will help, and it may early lysosomal amphotericin, etc., may save the patient's eye or such enucleating surgery, because the quality of life after such surgery, as you can imagine, would be extremely poor. Next, please. Again, we can see paranasal sinus, left ethmoid sinusitis, and it has involved the lamina papyracea. Once it involves the lamina papyracea of the cribriform plate, that means it can extend to the brain, and then it would become very difficult to save the patient. Next, please. Again, fungal sinusitis, invasion. We can see that it is involving the eye, it is involving the ethmoid and the maxillary sinus. Next, please. So again, the same thing. So we must emphasize early investigation and early treatment. Next, please. So as we all know, what are our preventive measures? Next, please. And we must continue to take care with whatever we have, lambda variant, new variants. We hope that we will all take care. The doctors are the worst sufferers, because if when patients are not cautious also, we cannot turn away any patient. And after all, many of our doctors also are quite senior or may have senior citizens or patients or people with comorbidities in their homes. And we carry the infection back to them. So let us hope and pray that we have reached 24% vaccination, that we reach 60-70% vaccination soon. So it is our duty to motivate people to get vaccinated and to follow all COVID appropriate behavior, as well as have early investigations and early treatment. Next, please. So everything we do in a pandemic seems alarmist, and everything we do after will seem inadequate, as it is happening to us. Nothing we did in the second wave seemed good enough. We ran out of beds, we ran out of oxygen, we ran out of doctors, we ran out of paramedical staff, and we hope that nothing like this ever happens again. Next, please. Thank you so much. I'm sorry for all the glitches that happened and for the delay. And I wish all the office bearers and the IMA at Kanpur the very best of luck for holding all these educational meets and for carrying on all these academic activities. Best of luck. Thank you very much. Have a good evening. Thank you. Thank you, Gurpreet. Thank you, Akhilesh sir. Thank you, everybody.
Very nice lecture and a beautiful presentation.
Thank you, Dr. Nandini, for taking time and really good testing for you also when somebody so close to the hospital and out of town and trying to coordinate between the Jamnagar and Kanpur and Mumbai is really a task, and you did it so very well. There were initial glitches, but then they were taken care of. Suggesting we are good doctors, but technically not as good. Thank you so very much, Dr. Nandini. And if there are any questions, I would forward them to you on an email and seek your clarifications or answers on that. Thank you so very much.
Dr. Nandini, I am Dr. Ravi Kumar, Director of Hypoxia here. And we read a lot not of this specialty, but I saw that your presentation was very unique and very important. Thank you very much for this statement. Thank you.
Thank you, ma'am. And
Thank you, Ji. I wish everybody a good evening. Thank you very much. Bye-bye. I take your leave. Sir, Dr. Akhilesh, may I leave?
Yeah. Thank you so very much. Thank you.
Thank you. Bye-bye.